Excuse me, can you listen, can you hear me at the end? Can you hear me? Yeah. So with the name of Allah, we begin. This is my disclosure. Before going further, I am grateful to Professor Misbah Kamil, Professor Adil Al-Sayyed, and of course, Ms. Hiba, Professor Abdul Basit for inviting me to give this talk. Now my topic is something new in diabetes, new developments in the field of diabetes. Now it's a very wide topic and very difficult to cut all the developments. So it is like closing and compressing River Nile in a bottle of mineral water. Virtually it is impossible. So I will go superficial with broad spectrum rather than going into depth. So this news was from UK, Britain, no, not UK, at the time Britain, 1916. And it says that the best treatment for diabetes is to drink good quality whiskey. Now we know that in 1916, there was no treatment for diabetes. Even insulin was not available. So these were the things because if you drink whiskey, it decreases glycogenolysis. So temporarily it will cause hypoglycemia. But fortunately, we have got so many drugs nowadays. This is very famous slide from UKPDS. It says 1% reduction of HbA1c will cause reduction in complications. Okay, 30%, maybe 40%. Why not 100%? Because we don't know diabetes yet. If you if you treat meticulously blood sugar, then there should be no complication. But 70% yes still occur, so we don't know diabetes. Our situation is like this. What about cure of the diabetes? So cure seems a sweet dream, far away from now. If beta cell replacement become reality, if gene therapy in type 2 become reality, if immune therapy in type 1, and one example is teplizumab, one step forward, I will talk on this. When vaccination in type 1 diabetes has become reality, when pancreatic, whole pancreas or beta cell transplant become reality, and when stem cell therapy become reality, only then we can think of cure of diabetes. Up till now, we have to use these drugs. So let us see what new things are coming. This is new classification. Yesterday, one speaker talked very well on this topic, but it is better than type 1, type 2, and GDM, but still insufficient, incomplete. Because how you will explain severe insulin deficiency diabetes in the absence of autoimmunity? Age-related is a vague term. Majority of us they are, mashallah, aged. So all will not develop diabetes. Who will develop diabetes? All obese person are diabetic. So still we will see more classification coming. Few words about latest technology. This is not a watch, it is glucometer. This is not a watch, it is glucometer. This is glucometer. This is glucometer here in ear lobule. And this is now very famous, we know Dexcom available, Libre available in very many countries. But this is new thing. It is incorporation of IT, information technology. We incorporated smart pens and all these glucometers, and we communicate with the patients very easily. CGM, 6 months. If you give small cut, put this instrument here, for 6 months it will work. This is the reality. It is available in some countries. This is the technology. So what next in CGM, continuous glucose monitoring? It is artificial intelligence. We have incorporated the CGM devices with the fitness watches. So fitness watches know what is the timing of the meal, what is your activity, what is the stress time, and it will help. Fusion molecule. A diabetic person has to take so many drugs, 3, 4, 6, 7 drugs at a time. So people are trying to combine these many drugs, 2, 3 drugs, genetically, molecularly in laboratory, so that one injection contains 3 drugs. One tablet will contain maybe 4 drugs, fusion molecule. One drop of blood is like your laboratory at home. This is instrument, these are the tests, put one drop, and at home you will see in seconds what is the blood urea, what is HbA1c. This is near future development. This is mini pump. You give incision here, put the small pump, and for 6 months, osmotically it works. Whether you put GLP-1 receptor agonist inside it or insulin for 6 months, this instrument will work. And these are different devices to avoid needle of the insulin. One weekly DPP inhibitor is maybe in near future, only Sunday you take one tablet. Now relatively new development are 2. Number 1, tablet semaglutide, Ribelsis, FDA approved, available in many countries. Injection tirazepide, 12 kg weight loss along with blood sugar control in 56 weeks in one study, tirzepatide. But in Pakistan, both are these drugs, they are not yet available, but in many countries, yes. Fatty liver, so many drugs in pipeline. So one study is going on regarding with empagliflozin. Glucokinase activator may be future drug. Sirtuins, in red wine, there is antioxidant. It is sirtuin. It is resveratrol. This is the mechanism of action. Cushing syndrome with metabolic syndrome. We know Cushing syndrome is a part of metabolic syndrome. So mifepristone is a FDA approved drug available in many countries. Nasal spray glucagon. Usually we give glucagon by injection, but for now in powder form we can give nasal spray. New insulins. Let us talk few words. Smart insulins. We are using smart mobile phones, smart computers. Now we will use smart insulin because they will sense hyperglycemia, postprandial, and automatically their intensity, potency will increase because more carbohydrate causes cleavage of the molecule hexamer. This is ultra rapid Lispro. It is not ordinary Lispro. So initially was beef, bovine, then came human, then came analog, now more analog, ultra rapid insulin. And this is new thing. Okay, so this drug, Lyme-Jevo, is FDA approved for use in children from age 1. Insulin degludec is available in many countries. Is it truly basal insulin 24-hour. Levemir and Glargine, they are not 24-hour insulin. They are 18-hour. This is truly 24-hour. Very slow release insulins possible in near future. Pegylated insulin work for 45 hours and maybe for 140 days. One injection, 3 months. Something even newer, once weekly insulin. One is from Novo company, other is from Eli Lilly, Icodec and BIF. Now, what is the mechanism? These insulin, they combine with albumin and other proteins and slowly released over the time of week. So for 1 week, one injection, phase 3 trial completed for Icodec. This is from Eli Lilly, phase 2 trial going on. BIF is the short name. Once weekly insulin, every Sunday you give one injection. Now F-pengalinatide is new once weekly GLP-1 receptor agonist and it is ready for FDA approval. Studies have been done, phase 3, and we will see this drug in near future. Now innovation in type 1 diabetes. FDA approved first drug that can delay the onset of type 1 diabetes, it is teplizumab. We became happy. For 3 years, no type 1 diabetes. Patients started phoning, oh, congratulations, doctor, the cure of diabetes has come, but this is not true. There are stages of type 1 diabetes. One is normal blood sugar, but antibodies present. Then abnormal blood sugar, with antibodies, but not clinical. Third stage is clinical diagnosis. So teplizumab act at the second stage to prevent third clinical stage. What is the cost? Very cheap, only $0.2 million. So it's a dream for our countries. Dream, very expensive. Now, issues with the screening. How you will screen stage 2 type 1 diabetes? Because only 10% relative have got autoimmunity, 90% no. So how you will screen the population? This is another problem. And then we don't know about side effects of the newer drugs. You see WBC count, lymphopenia is there, then cytokine storm, which we saw in COVID infection. And then risk of serious infections, hypersensitivity reaction, and other side effects. Time will tell us what are the side effects. Alternative route for insulin, this is oral insulin. Maybe we will take capsule of insulin, buccal insulin. Rectal insulin, unconscious patient in decay. Why you give IV infusion? Why not rectal? This is nasal aphasia, powder, inhaler, FDA approved, available. This is powder, better than Lispro. This is liquid inhaler of insulin. The name is St. John's, but it is the name. A patch of the insulin is in pipeline. When we give estrogen, testosterone through patches, why not insulin? What about insulin pumps? These are insulin pumps, initial heavy weight. You have to exercise for 3 months and then carry pump. Now, smart pumps, they are available. Even people are not knowing that the patient is wearing pump. Children, they are wearing smaller pump. This is semi-automatic insulin pump with CGM. Now, it's very expensive for our countries and need lot of education. We attended a 3-day workshop, and it was so complicated that we thought that flying aeroplane is easy rather than using these semi-automatic type of pumps. So many problems, relation with carbohydrate and calibration and so on. Dream of fully automatic closed loop pump is now almost reality, not reality, almost. Because pump will take care of us, we have to take care of pump. This is fully automatic pump because of these problems. Due to shortage of time, I cannot go into detail, but it is not like this you wear pump and do whatever you have to double check again and again with carbohydrate, maybe with calibration. This is bi-hormonal bionic pancreas, insulin with glucagon or pramlintide, because if you give insulin alone, this will cause maybe hypoglycemia. But if glucagon is in other chamber, it is like alpha and beta cell. If there is hypoglycemia, automatically glucagon chamber will open and there will be no hypoglycemia. But it is not yet available for general public. New biomarker of CKD, chronic kidney disease, serum cystine K, and genetic marker ApoL1. Oral drug in type 1, we were happy. SGLT2 was approved by EME, but FDA refused, and EMA took off the decision, cancelled the decision. The only possible drug is oral sotagliflozin. EMA approved in 2019, FDA not yet approved. It is a dual SGLT2 and T1 inhibitor, and this is given with insulin, but FDA still didn't approve. And thank you. I finished in time.